Hello, this is Surgical Teaching, and today we are going to talk about a purely surgical topic. Every medical doctor, GP, and even medical student should know about it. I'm going to try to explain it very briefly, and I hope it's going to be clear and fulfill your misunderstanding and curiosity if you have any. Today we're going to talk about the principle of surgical drain and what is the correct approach in a patient with a surgical drain. By the end of this lecture, you should know the indication for surgical drain, what are the types of surgical drain, what do we mean by daily maintenance, how can we remove it, what is the timing or the correct timing of removal, how can we prepare it, what are the methods, what are the potential complications, how can we follow up these kind of patients who have, and lastly we will have a very beautiful summary. I'm going to explain it, and it's going to be easy. What are the indication of surgery? هلا every patient who have to make it easy for you, it's important to know that each potential space that is going to collect any types of a fluid, or it's going to, or already collected the fluid, it should be drained out spontaneously. Okay, so drains, it could be used as a monitoring for in the surgical site or to remove accumulated body fluid. It doesn't mean previously accumulated, it could be potentially to be accumulated. Okay, so we can monitor the surgical sites, and the second thing, to monitor the accumulated fluid, like if there is any pus, blood, lymph, or bile, or air, even air. Yes, you can use a drain, and I will talk about it, from air that is accumulated in the body cavity, wound, or a potential space here. What I talk post-surgical, one of the following indication. Yes, emergency decompression. This is in case of chest tube decompression. It's a definitive therapy for what? Low tension pneumothorax. Okay. What is the definitive therapy? Percutaneous drainage, medication delivery, like in the certain lavage, gastric lavage, or giving an antibiotic to these medication. There is some note that the post-operative drain is now, or currently, it's declining, but some of the authorities are still indicate them. What you should consider in obtaining or choosing certain types of a drain, you should know, the choice of the drain depends on the intended use, the location of the drain, and the urgency of the patient to need this type of a drain. Okay, for the Jackson Bratt drain, I'm going to show you in a moment. It could be used to monitor anastomosis, or to drain a known or anticipated fluid collection, or to prevent the fluid accumulation in a post-operative peditubing. Yeah, it could be attached to a bulb suction, and I'm going to show you in a moment, or a wall suction. It could be made cut or not cut in a side hole. It should be cut sharply at an angle to distinguish it from a fragment. It's not important. These are kind of not. Okay. How can we categorize it by the position? You can categorize it into superficial and deep. Superficial, I mean there is a soft tissue abscesses or a seroma, or it could be used under a skin flap, or deep, you can use it as an intraperitoneal covering the anastomosis, or in a hollow organ to evacuate a certain types of fluid collection, or a deep cavity like in case of an abscess or a hematoma. Potential space like in a chest tube, we use it in a tension pneumothorax or open pneumothorax evenly. The abnormal channel, which like for example fistula, these are types of an examples of a deep fistula. How can we classify the drain tube? We can classify it based on two things. The first thing, the open system, the closed. Another thing is the active or passive drains. Okay, the open system, it drains into a dressing or a bag that is opens into the air. This is very important. So what are the types that drains into an air? Like for example, the Penrose, the sump, the corrugated wrapper. Yeah, the closed system that is sterilized, that would be evacuated into an sterilized chamber. It must release a vacuum in order the drain removal. one of the following advantages over the open system, that is less prone to a certain types of infection. This is an example for the types of a drain. In a closed system, we have Jackson Pratt, Redivac, Hemovac, Pigtail, T-tube, and Blake drain. In open system, we have a Penrose, a sump, a Foley's catheter, and even الاناتومي of a closed system. The closed system, we have something called the luminary tubing. This is the tube. It could be radio opaque due to the siliconized for the free flow of the fluids. We have an anti-reflux valve, we have a ruffle valve, we have a water seal in case of a chest tube, we have drainage reservoir and suction generating device. This is the suction generated device in case of Jackson-Pratt drain, where if you push or if you apply a pressure over this type of over the grenade, it will cause some sort of negative pressure, so it could pull the fluids inside it, and there is the plug that would cause an evacuation port for the releasing of what we call the collected or previously collected fluids. Next, we have a Penrose drain. The Penrose drain is composed of a soft rubber or silicone that could be placed inside the wound. Here is an illustration that how it could be replaced. This is a type of an open and passive drain. It is usually to be superficial. How can we remove it? By a gentle traction and unidirectional. It's very easy to be removed. The end should be sharply cut so it can be drained successfully. Okay, if any portion appear to be torn or degraded, you should use an x-ray of the wound. Why is that? Because it is considered to be as a foreign body inside the. It's very easy, I think. GP or Jackson-Pratt of what we call اللي هو grenade. It's a portable. It should be easy for the patient to use it. It has an oval grenade suction device. To establish the suction, you will pull the plug, squeeze the bulb. You should apply pressure over it or squeeze it and then replace the plug. Okay, the bulb should always be in a concave shape. It 170. It could be flat or rounded. Rounded, less dependable. Why is that? Due to the transition of the material. Next, the sump drain, one of the types of an open drains. Here you have a large lumen, central lumen, and two sump, okay, or highly fenestrated. It should create some sort of flow inside them, where it will allow the fluid to be drained successfully in the central lumen. Next, suction drain removal. How can we remove it? First thing, you should release the suction prior to the removal. Release the suction. Second of all, you should remove with gentle traction and unidirectional as well to prevent torning and even tripping of the tip should appear to be have sharply cut to allow successful removal. If any portion appear to be torn or degraded, further investigation, as I have said in Penrose drain, to rule out any the fracture of this type of a drain, the more likely to tear at the region of weaknesses, especially in the side holes. Never cut the drainage catheter through the side hole because it could be easily mistaken for a fracture. We will talk about the pigtail drain. One of the pigtail drain is considered to be open, صح? No, closed. Closed passive drain. So yeah, it's placed percutaneously عن طريق endoscopy. Traction with the central wires to form the pigtail. Here you can see the pigtail. The released when the wire is broken. It has a very small caliber, 4 to 5 at the end. Make sure to unscrew the cap to break the central wire, releasing the pigtail prior to the catheter removal, so you can easily to be removed. Okay, you should examine always the end of the catheter to know if it is present or not. So it should be ruled out to be cut or torn. If you are doped in if it is cut or torn, you should use another investigation like an X-ray of the area or a CT scan to rule out the retained drain fragments. Okay, a T-tube drain. This is one of the most beautiful, I think. T-tube, it's usually placed in the biliary drainage. Is one of the most common. It's not common actually, but we use it in certain types of patients. Know what is the indication of it. What is the indication of T-tube draining system? Okay, it's a central forward. You cut it as you need. Okay, as is needed. The T portion is placed in the common bile duct. The T piece, this is the T piece, it should be secured successfully in the biliary tree, and the exterior portion here you can see it should be sutured into the skin, and it should be connected into something to store bile inside that. It requires a cholangiogram, of course, prior to the removal. Why is that? To clear the biliary tree and confirm the patency of that one. It's usually not removed. It needs an actually sterile and how can we remove it? Usually it is crammed for 24 hours before the removal. In balloon dilatation in the selected urine may be performed prior to the removal. Why is that? To separate the fibrous sheet in order not to cause a very high. What are the complications of T-tube removal? The first thing, of course, in a logic way, is the bile leaks. Second of all, if there is any leaking inside the peritoneum, it will cause into a peritonitis. Third of all, it will cause a failure to the removal by manual traction, and it might induce fracture or breakage or torning of the catheter. Next, a Blake drain. It is a radio-opaque silicon or Teflon drain with 2 mm shell along the side, surrounding by a central core centrum. How can we drain? By the action of the capillaries. It will cause some sort of a pressure that will cause this type of a drain to work. It does not have any side wall, therefore it is less risk of catheter fracture at the weak points, and this is considered to be stronger in it. If there is any block where the channel cover need a tip, you should check the endpoints. Okay, how can we maintain it? To approach the patient with a catheter, the first thing you should describe the location of the catheter, or what we call the site of the catheter. Second of all, the type of the drain. Third of all, the amount of the fluid. What are the color of the fluid? Is there any increase in the quantity or the quality? Or is there the quality? I mean the color and the consistency. Is there any problem in that? Like if there is loss of suction or torn of the catheter or dislodgement and the appearance of the wound. Is there any presence of an infection? And you should know what are the manifestation of the infection. Okay, next. The drain should always to be kept clean and dry. Why is that? Because to prevent the contamination by the bacteria and the external environment in which it will be sterile. Next of all, to prevent stagnation with the associated clogging or reflux of the wound. Good flow should be removed. How? By removing invisible clog or tube obstruction عن طريق genital massage or stripping. And what do I mean by stripping? I will explain it in 1 minute. Always maintain an adequate suction to keep the suction bulb to be compressed very easily. Excess tubing should be taped. Excess tubing or should be cut, okay, or secured with the patient dressing. It should be secured in the patient chest, above the patient chest. Okay. Stripping, I mean by stripping, it should be by traction of the cord. Pulling of the cord away and trying to release the clogged or blocked tube or the blocked segment of the tube. Okay, it causes a transient elevation of the intramural luminal pressure by 20 to 95. This elevation it could be dangerous, especially if we're a mediastinal chest tube, because it might induce a pneumothorax and it will allow the air to enter inside the chest cavity. Okay, it does not significantly increase the amount of drainage obtained from the tubing, but gentle massage of the clotted area should be preferred to remove the clot away from the site of the obstruction. Okay, and certain situation you can use the fibrinolytic, but I don't think you should know the details about it. Okay, next, daily maintenance. Okay. A drainage bulb or the collection reservoir should be emptied regularly. It should be described what is the amount, what's the quality of it. When emptying, you should avoid introducing the bacteria to decrease the risk of getting or the risk of an infection. Okay, never re-advance the drain because it might dislodge and even causes an infection. Okay, when to remove the drain? There is no general rule, but if you want to. But if I can tell you as a general rule, you should drain it if it drains the drain. I mean, less than 200 cc, I think. Okay, the timing for the removal of the drain. Drains are removed when they are no longer needed. When do we say they are no longer needed? If it drains less than 25 milliliter in the GP for 2 continuous days, or if there is no output at all. Extended duration of action may be indicated in some certain up to several weeks. There are some general guidelines in the cases like in preoperative hematoma for bleeding. We will use it for 24 to 48 hours. Serous collection for 3 to 5 days, infectious 1 to 5 days, intestinal anastomosis 5 to 7 days, T-tubing for 6 to 10 days. Okay. How can we remove it, or what are the preparations for the drain removal? One, the first thing you should know what is, or what you should know your drain, review operative notes and talk to the surgeon and what's the outcome of the operation or whatsoever. Inspect the drain externally, notice if there is any visible signs of infection or breaks or even clots or whatever. Examine the radiographic evidence like an X-ray with CT scan. Know your patient very well. Examine the wound. Look for evidence of infection. Is it the time the drain should be come out? And I have explained what is the best time to remove it, if there any occlusion, and if it is medically indicated. Okay. Next of all, preparation for drain removal. You should gather the tools: sterile scissor, skin sterilizing agent, gloves, sterile gauze, tape. Pick your position, make the patient comfortable, clear any obstacle to removal. Don't make a mess because the nurses are going to behave you. Discuss the plan for the removal with the patient and the nurse, and the pain medication are rarely described, but they are preferably to be described in a patient with a drain removal because it's going to be painful for the patient. Next, how can we remove it? Before attempting the drain removal, make sure to review the patient post-operative, not to make a particular attention to the number of drains, with the types of drains, the location of the drains, and what are the indication for the drains themselves. If you are unsure about whether you should remove it or not, make sure to consult the seniors or even your surgeon. Inspect the external portion of the drain system if there is any break, clots, or whatsoever, if there is any visible infection or whatsoever. Remove all the dressing covering the incision site. Examine the wound of the patient. Remove an item that are securing the drain in place, the sutures, with staples, with tapes, or whatsoever. Release the suction. Apply unidirectional traction on the catheter. Apply a counter retraction to the patient because you are going to pull the drain. Examine the tip of the drainage for any irregularities or evidence of breakage. Cover the wound with a secure sterile dressing too, and always perform a serial examination at the incision site to notice any changes. Do you need anesthesia for the drain removal? I don't think so, but some types of drains, it should be removed by general anesthesia. We can give the IV medication, pain medication in some patients. It depends on the depth and the location of the drain, whether we are able to work on the patient while he's awake or not. Is he going to be in a very severe pain or not? We use as a local anesthesia as a lidocaine, may be helpful. The pain, it should be due to, or it could be due to irritating nerve fibers over the structures. Always you should sterilize the skin before reducing. Why? To reduce the risk of infection. What are the complications for the drain replacement? The complication, we have an immediate complication, early complication, and a late complication. The immediate complication, as easy as that: pain, bleeding, perforation or injury to the azale structure. The early complication: occlusion, leakage of drain or displacement, and even infection. Late: pressure and suction, bowel necrosis, blood vessel necrosis, and fistula formation due to the drain. Okay? There are some general complications like in pain, drainage from the insertion site, infection, fluid collection like in case of seroma, hematoma, injury to the adjacent structure, breakage of the drain or the tube of the drain. Yeah. But how can we manage the retail drain? As we said, you should have a radiographical testing like a CT scan or an X-ray. You should confirm the presence of a retention with the appropriate. Inform the patient and the team with the breakage. Antibiotic should be needed to prevent the infection because it's considered to be as a foreign body. Do not discard the portion of the device that is removed. And discuss the event with the risk management to learn from this type of. How can we follow it? By serial examination of the insertion site. Examine the wound for an infection or the evidence of the infection. Examine the wound in the patient for an evidence of tachycardia or fever or systemic signs of an infection. Monitor the labs of the patient. Unexplained leukocytosis or leukopenia. This indicates sepsis until proven otherwise. Antibiotic used only if there is any signs of an infection, and you should monitor the medication usage. Educate the patient educate the patient for the follow-up. Educate the patient if there is any persistent fever, if there is any sweat, chills, vomiting, diarrhea, redness, foul smelling, or from the wound, or increase in the pain inside, or found a foreign body in the wound. He should come to the ER, and you make sure to let the patient know if there is any some sanguineous drainage from the wound. It's considered to be normal. Okay, this is a summary